So the treatment goals can be palliative and curative according with the conditions of the patients. And we have to think that the stage 3 non-small cell lung cancer is a very heterogeneous stage of non-small cell lung cancer, because in the same stage 3 you may have totally different pictures of the patients. So you may have, for example, a large T volume or a large N volume. And this is really important to take the decisions, for example, for the surgery or for the radiotherapy for each patient. The second point is that the majority of patients have several comorbidities. And so, for example, in some cases, you are not able to go to surgery, maybe because they have COPD and they have some lung functional test not allowing some treatment. And the second point is that you have also different toxicity with the different treatment. And it is also important to have the decision patient by patient according with the also with the goals that are important for a single patient. For example, if you are 80, your goal is to have a good quality of life, and maybe if you are 60, your goal is to have a curative intent treatment. So it is a very heterogeneous field, and we have to think which is the better solution for each patient with the multidisciplinary team. Try every time to go with a curative intent, but sometimes also palliative intent can be important for a category of patients with several comorbidities or several problems in the life.
In locally advanced non-small cell lung cancer, I guess the major advances we have been doing in the last years is not to refine chemo, radiotherapy, change the paradigm there, but it's more about how to integrate these various modalities. We've been improving the integration of the same chemo and the same radiotherapy, but we've been improving how to deliver it to the patients. This can be done thanks to my opinion, to the fact that we collaborate better with the colleagues from other disciplines. So this disease, this stage, imposes the existence of multimodality meetings, what we call tumor boards, right? In order to be sure that every single patient has a personalized treatment, including or not, involving or not surgery, including or not chemotherapy, and really kind of timely framed in terms of being as fast as possible. But what, for example, has been shown in that disease is as far as you can, you should really deliver radio and chemotherapy at the same time. So this needs some organization, and it needs also to be really well kind of trained in terms of a multimodal team around the patient to be sure that the treatment is optimally delivered without delay and so on. So we've been improving the fact that it's not useful to give lots of chemo before and after, but you have to give chemo and radiotherapy in the same time. And it can be a short treatment, but this has to be like that. If you do surgery, you know that in this locally advanced, you have to give first chemo and then surgery. But everything is important. The time between one modality and the other one counts, and all these kind of things. So it's really about sharing together the best way to treat the patient. And that's where we have been making advances, not in the chemo, not in the radio, not in the surgery, but how to make people meet around the patient.
In locally advanced non-small cell lung cancer, the disease extent has an important place in determining the treatment strategy, just as the patient fitness has. So patients with single-station ipsilateral N2 disease have an option of undergoing chemoradiotherapy or surgery. And the tumor board can make the decision based on the extent of likely surgery and the fitness of the patient. If the patient is not a candidate for limited surgery, then we proceed to definitive chemoradiotherapy. In some patients with limited disease, we give induction chemoradiotherapy till about 50 Gray, to be followed by surgery if the surgeon feels that the preceding induction treatment is necessary in order to ensure a complete resection. In all other patients with multiple N2 disease or large bulky N2 disease or contralateral N3 disease, the standard of care is chemoradiotherapy, concurrent chemoradiotherapy, to a dose of at least 60 gray, given in once daily fractions of 2 gray. The European guidelines do allow us to go up to 66 gray, so 3 fractions more, in smaller volume disease where the chance of likelihood of damage, normal tissue damage, is limited. So basically 60 gray is considered the standard dose with 2 cycles of platinum-containing chemotherapy. It's often said that 3A is potentially operable, whereas 3B, non-small cell lung cancer, is not. But for radiation oncologists, that distinction is less important than the extent of the radiation field. So a smaller volume, stage 3B, is potentially just as curable as the stage 3A, whereas a very extensive stage 3A with extensive nodal disease can actually result in considerable radiation toxicity, for example, to the esophagus. So one of the factors which influences our strategy is the fitness of the patient to undergo full dose chemotherapy. So if a patient can undergo chemotherapy, then we look at the radiation fields and judge if the risk of acute toxicity, especially radiation esophagitis, is likely to be limited, or can be well tolerated by the patient. And then we would prefer to go to concurrent chemoradiotherapy at the start. So at least 2 cycles together with the radiation, which takes 6 weeks. So in the younger patients, there's often less doubt, but in the older patient population, clinicians are sometimes hesitant to do combined chemoradiotherapy. And I think the data from recent large trials internationally in North America suggests that the esophagitis rate is actually quite modest, closer to 6 to 15%. So many patients are willing to accept that risk if they are informed that there's a good chance of long-term survival from the lung cancer. So simply considering other treatment options because a patient is elderly is not appropriate. An elderly patient may have single-station N2 disease, with a very low risk of esophagitis, and it's quite acceptable to commence with that strategy. And if the patient doesn't tolerate it, to change the plan rather than presuming that a patient would be unfit to undergo that. Some of the newer insights coming from trials are that perhaps carboplatin-containing chemotherapy, which are sometimes better tolerated in elderly, seem to be just as effective in the combined modality setting. Especially in Europe in the past, there's been a tendency to consider fitness to undergo cisplatinum-based chemotherapy as a criteria for combined modality. Perhaps if these ideas are critically evaluated again, we might put more patients into concurrent chemoradiotherapy if they're only fit for carboplatin. So I think we have to have a rethink. In North America, it's much more popular to use carboplatin regimens, whereas in Europe it's less. And use of carboplatin for concurrent chemoradiotherapy may allow more elderly patients to undergo concurrent chemoradiotherapy for locally advanced non-small cell lung cancer. In expert multidisciplinary teams, it's often the tri-modality approach is considered. So that is to say chemoradiotherapy plus surgery. In such a patient population, it often means that limited surgery may be possible, for example, a sleeve lobectomy, or a more radical surgery may be possible if the patient undergoes induction therapy. But it's important to realize that this decision should be taken in a multidisciplinary team before the patient undergoes any planned treatment, so that the surgeon is prepared and gives a commitment. The patient is aware of what the options are. And this treatment strategy is best limited to patients who are treated in expert centers with radiation and surgical expertise available. It should not be an ad hoc decision in a patient who's undergoing planned full-dose chemoradiotherapy to stop suddenly and then say, well, perhaps we should have thought about surgery. It's confusing for the patient, it's bad for the planning, it might result in unnecessary interruptions and delays, and the surgical team may not be happy to suddenly be asked to consider this late in the treatment path.